I would like to start by introducing someone who I believe is known to most of us in the room, if not all, Dr. Mojisola Odeku, who is the Senior Officer, Advocacy and Government and Multilateral Relations and Strategic Program Partnerships, Nigeria, Gates Foundation. Please, a round of applause for her. You're welcome, ma'am. I would also like to introduce Dr. Binyerem Ukire, Director of Family Health Department, Federal Ministry of Health. You're very welcome, ma'am. And Dr. Kelechi Ohiri, Director General and CEO, National Health Insurance Authority, who is still on his way. Please, I think would like to take welcome addresses from either one of you, starting with you. Starting with my director, ma. Please, a welcome address from you, ma. Round of applause. Please make her welcome as she makes her way to the microphone.
Oh, thank you very much, even though you've taken me unawares. I was thinking I was coming here as a visitor. On behalf of, I would say, the Coordinating Minister of Health, Professor Muhammad Ali Pate, I wish to welcome every one of you, particularly our panelists, Dr. Moji, and all the other panelists and all participants here in the room, the media, NSSF, PIC, NHIA executives and officials here present. I want to say you're welcome to this very important afternoon meeting. That will be giving us the opportunity to be discussing on maternal health equity, the role of health insurance in promoting women's health. I wish us all a very interesting meeting, a very satisfying meeting, where we are going to be making bold recommendations that we will actually set out to implement. Thank you.
Next, we would like to hear from Dr. Dekuma, very briefly. Please, a round of applause for her.
Thank you very much. I would like to stand on the protocol established by my director. I'm really very excited that she's leading this discussion as government. We're here as representing the Gates Foundation on behalf of the country director and our other colleagues who would have come in here as a tribe, because this topical issue is very important right now, especially with the shifts that we have globally in global development, and as the country is looking ahead in optimizing its domestic resources, even though it's not enough, but the little we have, making it to work for us. I'm particularly pleased that we rounded up this discussion today as women's wellness. Health is a pillar of the wellness, and there are so many other issues, that surround us attaining the quality health we would like to see as Nigerians. And we do know that the women is at the center of it all. Even our national anthem has finally realized that, motherhood, So it's really very collective way of us looking for how do we manage and breathe through the disruptions, but enabling wellness of women as a wholeness, not just the health. So looking forward to discussions, to learning from colleague panelists, and also the key takeaways that we can use to continue the conversation beyond this room. Thank you.
Thank you so much, Ma, for that. Before we go ahead, let me also introduce, we have the General Manager of the Ekiti Health Insurance Scheme is joining us virtually from Ekiti State in person of Dr. Charles Doherty. Dr. Charles is online. I think he has a few words just to welcome us all to this event. Dr. Charles, can you hear me, sir? Okay. If we're having difficulty connecting, let us just move on. Let me welcome the Managing Director of the Nigerian Solidarity Support Fund, who has today put together this event, Dr. Fejiro Chinyewoko, to come and give our opening remarks to this audience. Thank you very much.
Good morning, everyone. Good morning to our panelists, to our speakers, to our participants in the room, and to our participants online. It's a pleasure to be here again today to have another insightful, engaging conversation on our health equity and health system in Nigeria. Today, we are going to be discussing something really important and pertinent to us, which is women's wellness, maternal health equity. I would like to talk about NSSF for a minute because NSSF is the one organizing and convening this meeting alongside with the PIC. So just to introduce NSSF to you, we're a non-for-profit organization focused on pertinent health issues, especially using advocacy and policy development to achieve this. Our vision is one. It is to improve the health systems in Nigeria, equitable health systems, and a healthier Nigeria. We have started NSSF since 2020, and this is going to be the 5th year of NSSF in Nigeria. NSSF was born as a collaboration of NHIA and the Global Citizen to contribute and to strengthen health in Nigeria. For the past 5 years, we focused on pertinent health issues such as COVID-19 vaccination, childhood immunization, and now we are focused on health systems, strengthening especially women's health, with a narrow focus on improving access to health using health insurance. That's what we've done in the past 5 years, and that's our focus right now. This is our 7th Fireside chat. We've had several other Fireside chats where we've talked about health innovation, technology for health, vaccination, and this Fireside chat is focused now on maternal health equity. We are privileged to have you in our midst today and our distinguished panelists because we know they will bring a wealth of knowledge, understanding, and experience to the room. We are not just here to talk about the issues. We are here to push for a way forward. And that is the bone of our conversation. We are assuring Nigerians that if we make this a very well-rounded conversation and contribution from everyone, seeing that this is an issue that affects everybody, we're sure to come up with solutions that we can propose to the government to implement for maternal health equity. Today we'll be focused on policies that are focused on women's wellness and how health insurance can bring that to life, bridging the gaps that we see in the health access space. So thank you again, once again, for joining us for this for this Fireside chat. And we look to having contributions from you online and in person. Thank you very much.
All right. Thank you, Dr. Fejiro, for that welcome address. I'm being told that the media is ready to take Dr. Charles Doherty's opening remarks as well. Dr. Charles, can you hear us? Can you go ahead, sir?
Yes, I've done that. Okay, thank you. So let me appreciate the moderator. Good afternoon, ladies and gentlemen. Let me continue with the already established protocol. My name is Doherty Charles, as already been announced. I'm the General Manager of the State Health Insurance Scheme, and I'm representing the Honorable Commissioner of Health, Dr. Oyebanji Filani. We are glad to join the world most especially the participants here today. In this wonderful program, Breaking Barriers to Maternal Equity, the role of health insurance in promoting women's wellness. And I think this has been the focus and a very important area whereby all health insurance schemes in Nigeria and Ekiti State in particular are skilled into. We need to protect our mothers, we need to protect our children, we need to protect all our under 5, and we need to increase and improve on our indices so that we can achieve our universal health coverage. I will be joining you today, and I'm glad to be here, as I've said. And I want to use this opportunity to welcome all other participants to this program. Thank you.
Thank you very much, sir, for those remarks. So we'll delve in right now to just lay a background to the conversation today in the room. And I'll be speaking to some of the initiatives that NSSF has done or is currently doing. My name is Adedayo Adebigbe. I work as program manager for the Nigerian Solidarity Support Fund. Please can the presentation come up? All right, so Dr. Fedro has told you what NSSF is about, what our vision and mission is. And so I won't delve so much into that again. Next slide, please. Yeah, so this is who we are. NSSF was founded by the Nigerian Sovereign Investment Authority and Global Citizens. And then, next slide, please. All right, so these are some of the initiatives that I'll be speaking to today. We have what we call the WeNaija Impact Cohort, and we have what we call the WeNaija Impact in Ekiti State. WeNaija is trademarked by the Nigerian Solidarity and Support Fund. It's our trademark platform whereby we have youths coming together to advocate for different health issues in Nigeria. And we're walking you through some of the things that we have done with this Impact Cohort. Next slide. All right, so we know Nigeria has its challenges. We also know that young people make up a significant proportion of Nigeria's population, and we know that through their talent and digital creation skills, they are well positioned to make an impact. However, realizing that their potential remain untapped due to lack of awareness and other factors, this is why we are currently doing the initiatives that we work on. Next slide. Now, talking about the WeNaija community. 4 years ago, we established the WeNaija community to mobilize youths that are specifically passionate about improving the Nigerian healthcare system. And this platform has evolved over years to create change makers in Nigeria, right? And they have explored various health challenges. I recall that in the last 4 years, we've done HPV campaigns, we've done drug abuse campaigns, and different issues that are facing. And one of our flagship is also to assess primary care centers across different parts of Nigeria. I'm also proud to announce that we have WeNaija community members that are spread across all the 36 states of the Federation, including the FCT. Right. We also have the WeNaija Impact Cohort. And as you can see, these are some of our cohort members all across the country. Next slide. Next slide, please. For the Impact Cohort, it's a 4-month program where we advertise for youths to join. We bring youths together, especially for youths that have creative advocacy skills and are passionate about Nigerian care system. So we run a campaign, we ask them to join, people sign up to join our cohort. And then before they join the cohort, once they have joined the cohort, we have a capacity building session. We have experts come together to speak to them about various topics. In the last cohort that we held in February, we had people from NHIA, we had people from UNFPA, we had people from Nigerian Primary Healthcare Development Agency, and we had people from the academia also come to speak to people about what they were expected to understand about the Nigerian healthcare system. We also had people that were making waves in the advocacy sector in Nigeria, digital content creators, people in the media that could teach them how to sell the Nigerian healthcare story to the public and how it could be accepted. And then for WeNaija Impact in Ekiti, we're also working with youths. The Ekiti State government has what we call the state health vanguards. They are youths that are brought together to advocate for different health issues in the Ekiti State, and they are spread across each political ward in the state and across the 16 local governments of the state. That program is already in establishment. So what we did as NSSF was to key into the youths that are already doing different things and to introduce health insurance advocacy to what they were doing. They were already doing different programs in malaria and doing quality improvement across their primary care centers and their hospitals in Ekiti State. So what we did is to train them on what health insurance was. Ekiti State has their own version of health insurance, which is the Ulerawa project. And what we did was we organized a TOT among focal persons in Ekiti State across the 16 local governments. We now trained all the 354 state health vanguards that we had. And from there, we have had them collect data and do so many forms of advocacy in the state. All right, so for the WeNaija Impact Cohort, we have 2 cohorts in a year. One runs between February and May. We're rounding up the first cohort. And then the second one runs between July and October every year. Next slide, please. All right, please, let's move on so that I don't... these are some of the objectives and the outcome of our cohort, community impact, increase the awareness, to create sustainable solutions, and also to engage policy. And that's part of what we're doing here today, giving you a feedback of what we have been able to do. Next slide. All right, so for the impact cohort for this year, we have one which is the reproductive, maternal, newborn, and child health stream, and we have the health policy stream. For the reproductive, maternal, newborn, and child health stream, it focuses on interventions that are relating to the reproductive health, sexual health, maternal health, as well as promoting gender equity. While the health policy stream focuses on things that improve policy development, vaccination campaigns, improve health insurance uptake, screening for non-communicable diseases and the likes. Next slide. So just like I've explained earlier, we have a recruitment and selection process, and then we have the capacity building session so that we can equip our youth with the necessary skills and all that. Next, please. All right, and then this is our methodology. Our youths have to conduct field visits to engage local communities, and then they use different survey methods, interviews, and focus groups to gather data on health challenges. And they also have collaborative workshops to analyze some of the data that we have seen, and then hold brainstorming sessions with stakeholders to develop feasible solutions. Next slide. All right, so this is our timeline for the impact cohort. The capacity building session is always 2 weeks, and then the community and intervention and data collection is 8 weeks. At the moment, our community members are in the problem identification, co-creation, and outreach phase. They are done with the first 2 stages, and they are now in the 3rd phase. Next slide. Okay, next slide, please, again. All right, so this is the spread of, our present cohorts, this is the spread that they have at the moment. You can see that they are spread across all geopolitical zones in Nigeria, Northwest, the Northeast, North Central, Southwest, Southeast, and the South-South. And this is just showing you what the distribution of our present cohort, right? But we have WeNaija community members spread across the whole Nigeria. Now, what we also do is that for the cohort sessions, when we do the capacity building session, we also look at people that made attendance, because we don't want to push people out there, right, that do not have the basic knowledge on health information and what to do. So we ensure that attendance at our capacity building session is optimum. So people that don't make the required number of attendance for the capacity building session, we don't allow them proceed to the next phase of data collection and advocacy. All right, next slide. All right, so these are just some of the communities that we have been able to engage so far. We have the Nigerian Union of Pensioners in Plateau State, Tricycle Operators in Tanke in Ilorin, Sandfillers Market in River State, the Market Women Association in Jigawa, Landlord and Tenant Association in River State, Nigerian Union of Teachers in Kano State, next slide, Bus Drivers Association in Ijebu, Nigerian Union of Road Transport Workers Kano Municipal Council, tricycle riders in Enugu State, Ankara fabric sellers in Balogun Market, and Okiosi community. Now, before I go to the impact report, I also need to say that for some of these communities, we ensured that our community understood the need to focus on informal workers specifically. For health insurance, we realized that, for the formal sector, a lot of people have made strides. Organized private sector, the NHIA covers formal sector workers, and we have many state governments coming in to have health insurance work for their state formal sector workers. But the main gap in health insurance still remains the informal sector. So we ensure that the impact cohort can focus on the informal sectors, and that's why you can see the different communities that are being engaged, and we stated specifically that that's what the preference are. Now, for the impact cohort, for data collection, and so far we have been able to collect responses from about 3,000 plus people across the country. And we've noticed that about a third to a third of our respondents had a family income that was less than an average 100,000 naira. But what we mean by family income, we mean both for the husband and the wife. All right, next slide. All right, so this is just looking at this, we saw that majority of our respondents are people that are within 30 and 50 years old. Next. And many of them are self-employed. Just about 30% have paid employment, while we have about 13.6 non-employed. Yeah, employment means that people that earn an income, no matter how small the income is. Next slide. All right, so when we looked at the awareness of health insurance among this group, we found out that about almost 40% of them had even never heard about health insurance before. They didn't know what it was. Hospital workers, family and friends were the main source of information for those who were aware. And when we asked them if they know who controls health insurance in Nigeria, 41.2% said they had no idea, while about 30% said it was controlled by both federal and state governments. About 28% of our respondents felt that health insurance was government's way of collecting money from people without actually doing anything. So that's a huge, huge problem that we found, even among 28% of people. Next slide. All right, so we also found that a lot of people think that awareness on health insurance is still inadequate. And you can see that number is a 3.2%. They feel that, because they felt that many of the way they knew about health insurance was people telling them what it was, or when they go to the hospitals, health workers telling them to sign up, right? But they still feel that, health insurance knowledge awareness in Nigeria is inadequate. While, of course, the majority also feel that it's also a very easy way to have quality healthcare in Nigeria. Surprisingly, we also found out that almost half of them felt that out-of-pocket payments was what they preferred. Even after we had told them about what health insurance is, people felt, okay, we still prefer to pay out of pocket. And that's also a very concerning number that we found out. Next slide. All right, and then we found out that about 59% of them said they had known somebody who they enrolled for health insurance and did not enjoy the services that were rendered to them. For those of them who had a complaint, a lot of them complained about drug availability being a problem. Some complained about poor hospital services being the problem, while about 24% also complained of HMOs being the problem of health insurance. Next slide. All right. So when we now asked about enrollment and usage, we had asked for their awareness and we had asked for their perception. 68.1% said they were not enrolled under any form of health insurance scheme. For those that were enrolled, we found out that majority of them were under the state health insurance schemes, some by the federal government workers, and then we also had a very small number coming under the private health insurance from HMOs and tertiary institutions. Next slide. All right, so when we asked them what usually constitute the services that they use whenever they are ill, you can see that majority said it was for malaria, diarrhea, and other minor illnesses, right? We found out that antenatal and other forms of maternity care also had, a significant proportion. And then majority also went back for drug refills. Many of them living with chronic illnesses went back for drug refills for some of their other illnesses. Next slide. So most significantly, we asked them what the barriers that they felt were affecting utilization of health insurance in the state. And we can see that the majority said they didn't know where to register, which was very, looking at the numbers of people saying they were not even aware, a lot of them said they didn't know where to register for health insurance. Some of them said there was delay in attending to patients. And then you see that 9.55% or 10% said they don't even believe in the government. And that's why they think that they will never register for health insurance. And this also one of the fulcrum of what our cohort is about. Identify what the barriers are, use these barriers to advocate, to do education. One of the things we did, and one of the things we did in our capacity building sessions was bringing NHIA into the picture. So at that session, NHIA was able to tell them what the spread was across the country. If people want to register for each cadre, where the state offices were located, each state also having their own personal health insurance scheme, NHIA also having zonal offices and state offices where if they are interested, they could register for health insurance. Next slide. All right, and then willingness to pay, for health insurance. Of course, we know Nigerians don't like to part away with their money. So it was not surprising to see that, it was very surprising to see that they were very willing to pay. And then when we further delved in to ask them how much they were willing to pay, majority of people said 10,000 to 20,000 annually was what they were willing to pay for health insurance. In some of my own capacity building sessions to our core members, I always make them understand that Nigeria pays so much for so many other things, right? I always tell people that food, transport takes a lot of our money. Even, for instance, when people go for weddings, for instance, people pay so much to take ashwebi, you pay the tailor to sew it, you do makeup, you tie gele, you do all those things, right? Just to attend one event, and then you are willing to pay 10,000 to 20,000 for health insurance in 1 year. So it's just telling you how much value people pay to health insurance on themselves. Next slide. All right, so for the WeNaija Impact in Ekiti, also working with a group of youth again in the States. Next slide. Next slide, please. I don't need to go over this. Next slide. I've explained this. Our goal in Ekiti is to achieve a 10% increment in utilization in Ekiti State. We have had multiple training sessions, both physically and virtually, across all the 16 local governments in the state. We had a TOT for focal persons, and our training areas were generally on how to use various methods to collect data and how to conduct advocacy. Next slide. So far, working in Ekiti, we have received about 447,000 responses from people across all the 16 local governments in the country. Next slide. And we can, looking at the awareness of across the 16 local governments, we can see the Oye local government having the highest awareness. And also, people look at that don't have awareness, we can see that Ado Ekiti, which is the state capital, surprisingly, right? Recording the highest number of people who said they were unaware of health insurance in the state. Next slide. All right, so when we also asked them about the type of health insurance that they were presently using, of course, it was not shocking to find out that their state version, which is Ulirawa, of course, that's what is mostly propagated by the state, is what they were mostly aware of. NHIS and private recorded very low numbers of in that regard. Next slide. All right, for the services that were mostly utilized is malaria, right, in the state. Malaria, we found out that also that was closely followed by immunization and antenatal, thereabout, and family planning services. And these are the distribution across all the 16 local governments in the state. Next slide. All right, so we also looked at what the barriers were affecting utilization of health insurance in the Ekiti State. And majority of them, so this is a beauty about Ekiti State that I must say here. So Ekiti State has also implemented something that, because of the abuse of health insurance, a lot of people go to the health facilities because they want to get drugs, right? So Ekiti State has a policy whereby you require testing before you can be treated. They don't just treat arbitrarily. Coincidentally, we found out that that was what people said were barriers to them not even going anymore, because when they get there, they tell them that you must get a test before we know what is wrong with you. And then people said they were not going back there again. So it was a very big barrier that we noticed, And then there were also a few people that also mentioned that they had no reason, they were just not interested. And then distance to designated health facility was also very popular among what they said. Now, about this distance, we found out that, for Ekiti, they have a designated health facility. the Model 1 health facility where people can go and access either the basic healthcare provision fund or their own state version of health insurance. So a lot of people, and that health facility is located in one ward. So people from other wards need to go to that place. So they also felt that, distance was a problem to us. So we are trying to see how we can increase the number of facilities across the state that can offer, and take away the distance barrier problem that is there. So this is what NSSF is trying to do. All right, next slide. All right, we also found out that health worker attitude also featured as a major barrier, of course. And, I was on ground in Ekiti and I was able to go around and I found out that sometimes I do not blame these health workers. They are overstretched. One health facility has just maybe one doctor or even one supervisor of health. And that person, when you get there, you have about 40, 45 patients. In fact, there was a day, the person that was on night duty was the same person continuing during the day. And it was very erratic. It was very irritable, So you could understand that manpower problems was a problem. But the patients didn't see it that way. They just felt that it was the attitude of the health worker. They were snapping at them and all that. So it's also a barrier that we noticed. Of course, we also saw in some local governments that lack of belief in the government was also playing a significant role in that. Next slide. All right. We also found that, inadequate manpower, we have said. And then, of course, another thing we also noticed was that the coverage doesn't cover their ailments. Yeah. So a lot of them felt that because the state version of health insurance covers just a few things: malaria, minor illnesses, antenatal care, immunization, family planning. For now, in Ekiti State, it doesn't cover, chronic illnesses, right? And this is something that NSSF is also very passionate to see how we can get people to support the state so that the coverage can be expanded, so that it can cover more things. So a lot of people feel that the present version of health insurance in the state was not covering their ailments. And so for that reason, it was a barrier to them. Next slide. All right, so I'll conclude by saying that NSSF, through the support of the board and the general support of all our partners and donors, continue to play its part in improving health indices in Nigeria. So I'll stop here. Thank you very much.
Thank you very much for that very detailed presentation. Adedayo, I'm sure anybody in the room who wasn't so conversant with this topic at this point, it's all beginning to come together and make sense. At this juncture, I'm told that we have one of the NSSF We Impact Cohort members, Steve Isaac, in the room. Okay, so please join me in welcoming him for his presentation. A round of applause for him, please. Please make it louder. Thank you.
Thank you, gentlemen and ladies. My name is Stephen Isaac, and I'm here to present an advocacy on the health insurance. I don't know if my slide is ready. And what I would like to start with should be my video. The field experience. I would like the video to be played. I think we are all neat today. Okay.
On the National Health Insurance Scheme, NHIA.
Where did you first hear about NHIS?
During a recent advocacy outreaches, I found myself engaged in community service on the National Health Insurance Scheme, NHIS.
What are the biggest challenges you face when trying to get like to enjoy yourself?
As a cohort with the NSSF, I introduced myself each moment to the participants.
Actually, cohort of NSSF, and I'm health.
But many of them assumed I had come to distribute palliatives, otherwise they wouldn't listen. Their skepticism was both amusing and frustrating. Every session, someone would ask about the link between the NHIA and NSSF, often with a focus on monetary benefits. I responded with a smile, though I was inwardly disheartened by how transactional their expectations had become. Still, I valued the interactions, especially with participants who had some knowledge of the NHIS.
Please, can I ask you which office is that? Did you think people in this community have enrolled or have enough awareness about health insurance?
No, they
If they are not aware, why do you think?
because there's no popular no.
Have you or anyone you think
These individuals sparked deep conversations, openly sharing concerns, experiences, and doubts. Their stories revealed why many remain outside the scheme: lack of trust, poor service delivery, and limited awareness. This gave me the chance to clarify more about the NSSF's role as a key partner with the government in revitalizing the NHIS and improving access through better managed health services. I asked thought-provoking questions, such as, what do you know about health insurance? Why do people avoid enrollment? Is it because of cost, distrust, or poor services by the health service providers? And if these are true observations, what can be done to build trust and improve the access for quality health across the nation? One participant among many seated there, Mr. Innocent Makiko, a police officer who spoke, shared his frustration. Despite enrolling, he received poor treatment and faced hostility from providers. Though he reported the issue to his HMO, no action was taken, even after multiple complaints. His story reflects a deeper problem about the NHIS scheme, one we must address to build a health system that truly serves the people.
Thank you very much. You can all see I am in the field. So these are the deep experiences that I have when I confronted most of these people in the community. I speak to them one-on-one for me to be able to find out why are so many people not partaking in the health insurance. What is the problem? So my encounter with them was something that sparked, the grievances that so many people have about the health insurance, talking about not being accessible, and enrollment centers, and they are not present, and people maybe that they have already enrolled, they are not covered. Some of the treatments are not covered. Most of the treatments that are covered are only preventive treatments. So during our capacity building, I learned so much from, sorry about that. I learned so much from our presenters, our teachers, our role model, those who came, to see us through before we could engage the public on this matter. So, me being in the field and from the experiences that I had, I confront some of these issues intimately for me to be able to find out what is the reason. And that's why I've come here to share with you what we experienced. What I experienced during this capacity building is that out of 100% of the people that I met, let me just say about 10% say that they are not going to partake in health insurance. More than 90% say that yes, they are willing to partake in health insurance, but the accessibility, that is where the problem is. How can we do that? I went on to teach them, expound to them that most of these things, that is why NSSF is here, because they are serving as a line that is dividing in between the health provider, the NHIA, and the rest of them. Then we have the subscriber, which are the enrollees. So these people, NSSF, are a bridge builder. So they are the one that are going to form the health policy to bring all of these things together to make sure that the problem that they have been having, most especially the health provider, where you find out an enrollee or somebody that is already in the scheme experiences some kind of hostility during his treatment or not being taken serious because of what the let me say the system or the corruption that is already in the system. So they don't take those people serious. And that is why you find out that many people don't even go. They don't even want to go, even though they are enrolled. They don't. So they prefer out of the pocket treatment because they know that, yes, they can be taken care of seriously or they can be taken serious. That's one of the things that our enrollee complain much about. And I told them that, please, henceforth from today, we're going to come up with a very vital policy that we can make sure that one-on-one, most of this enrollee can be reached. And most of this problem that they are having right now, they can no longer have them if they can just give us their time and we talk to them. Thank you. That's most of the things that we discussed with them. And I found out that yes, they are willing. And as much as the government is willing to partner with us, we are ready to go an extra mile to make sure that these people, in their large number, they will come out and they will build more hope, they will develop more hope concerning the health policy and the health insurance. Thank you very much.
Please let's encourage him with a round of applause. Thank you very much, Mr. Steve Isaac. So at this point, would like to pause. I know it's been a lot of information from both Adedayo and Mr. Steve. I don't know whether we have any questions. Very briefly, we have to make it very quick so that we can jump into the next thing on the agenda. Does anybody have questions for Mr. Steve? Okay, all was clear. All right. If a question occurs to you, please, while we've moved on, feel free to scribble it down, and we can take questions towards as we go on the day. At this point, I'm told that our third speaker is on ground, right? So I would like to move to the fireside chat and panel discussion. I'm seeing some new faces that we had not seen initially. Please, sir, there's a chair for you in front here. So I would like to start by saying good afternoon, distinguished ladies and gentlemen, and a very warm welcome to this session on advancing women's health and collaboration for better outcomes, entitled Breaking Barriers to Maternal Health Equity, the Role of Health Insurance in Promoting Women's Wellness. Do I see a hand at the back? Okay. My name is Dr. Somwebu, Public Health Specialist with the Policy Innovation Center, and I'll be your moderator for this fire chat discussion. I would like to start by inviting our esteemed panelists to join me on stage here. Please, I would like for you, when they start walking up, to give them a rousing round of applause for making time out of their busy schedules to be here. In no particular order, I would like to start by inviting Dr. Mojisola Odeku, Senior Officer with the Gates Foundation. A warm round of applause for her. Next, I would like to invite to the stage Dr. Binyerem Ukire, Director, Family Health Department, Federal Ministry of Health. A warm round of applause. You're welcome, Ma. And last but certainly not the least, I would like to invite Professor Chima Onoka, Senior Special Advisor to the Director General and CEO, National Health Insurance Authority. A warm round of applause for him. You're very welcome, sir. Before we get started, please bear with me while I go over a few housekeeping details. Each of our esteemed panelists will have a total of 3 questions lasting 4 minutes each. I want to appeal that we stay within the bounds of the 4 minutes so that we can finish in a timely manner today. So there'll be a first round of questions followed immediately by a second round, and then we'll throw the floor open to the audience for questions. And then if time permits, we'll come back to the panelists for a third round of questions. But before we get started, allow me to set the tone for the discussion for today by laying a little bit of a background, because I see that not everybody in here may be as familiar with this topic. So just to bring all of us up to speed, bear with me while I read. Proper healthcare for women is essential for sustainable development, yet many African communities, especially in Nigeria, face significant challenges in accessing quality maternal care. Nigeria's maternal mortality rate stands at 512 deaths per 100,000 live births. That means that for every 100,000 babies born, 512 of them lose their mothers. This is driven by financial constraints, poor infrastructure, and cultural barriers. These disparities hinder progress towards achieving Sustainable Development Goal 3, which is health and well-being for all. Health insurance can help bridge these gaps by reducing costs and improving access. But the current schemes that we have often exclude critical services like cancer screenings, family planning, cesarean deliveries, and postnatal care, unless under premium health plans. Many maternal health programs lack sustained financing and appear not to be designed with gender-specific needs in mind. Prioritizing women's inclusion, gender equity, and mental health in program design is crucial, given their central role in reproduction, family stability, and national development. Our discussion here today will examine how health insurance can better promote maternal health equity for all, particularly the most underserved, and identify practical, impactful solutions to perceived gaps. So, I will join. So, for the first round of questions, I will start with you, Dr. Odeku. Given your role with the Gates Foundation, which is a leading partner in the health sector addressing concerns of maternal mortality and improving maternal health outcomes, from your perspective, what are those key barriers that are preventing women, particularly those in underserved communities? Adedayo just made his presentation on how the most vulnerable are mostly those who are in the informal sector. So for such women, what are those barriers that prevent them from accessing quality healthcare, and how can health insurance help bridge this gap? Over to you, Ma.
Okay, I have 3 minutes, right?
You have 4 minutes.
4 minutes, okay. So I would like to bucket them into like five themes. And those themes were actually highlighted by the previous presenters. And the most important one that I look at is the issue of cultural factors, mindset. We are not in a place where, even though we do informal traditional insurances through our isusus and cooperatives and stuff, but being able to understand the essence of pooling for health insurance. Most importantly, people will say, well, I enlist and I pay my premium and I don't fall sick. Somebody else is using the money that I paid for. Not knowing that even though you don't fall sick, you may have an emergency once in a year that your premium that you paid is like 0.1%, and that system would take care of you. So being able to do a mindset shift, and that comes in a lot of social behavioral change communication, not awareness. Awareness is just an entry point. we need to deploy the science of social behavioral change into our messaging. That is key, because that is what will change from those who are to take action and internalize and use the efficacy of peer-to-peer to do those peer-to-peer advocacy that we can't do, because that is a major factor. Another factor is women's healthcare decision making, right? It's a whole lot of complex issues between household economics and where do I deploy my money and all that. So making health insurance part of the social norm of life, which we do deploy in some other economic insurances by, you have a SUSU, we do take insurance in other ways, but how do we deploy it? The other limitation is, which the presenters have alluded to, is that there's limited coverage of gender-specific needs. Okay? Everybody is grouped as humanity, which is right. But there are some gender-specific needs. We do know that those who do not seek health at all, or even the men, they have very poor health-seeking behavior. Most of them don't even enlist on health insurance or any other health care, right? What are those specific needs that will ginger them in, right? For the maternal side, which is a discussion of today, most of the schemes do not cover lifestyle reproductive issues like hormonal care, women with PCOS. You know what's trending now? A lot of women are coming out talking about endometriosis. Is not covered, not seen as routine, is seen as a special care, right? Most women will cover delivery ANC. We don't cover mental health like postpartum depression, postpartum psychosis. We don't cover that, right? So some women see themselves with those unique needs that that scheme doesn't cover. So why should I enlist, right? That's why they will go for the out of pocket and get specialty care. But if you look at those within the lowest wealth quintiles, they can't afford it. And so that's where the equity comes in. Illiteracy or low literacy is another issue which most of the cohorts has come about. So how do we present health insurance in a less technical way? Financial hardship. We know that 52% of Nigerian women report financial hardship, and that's why government of Nigeria is looking at financial inclusion for women to be able to enable them to largely, even though they say they want to pay out of pocket, they can't really afford the out of pocket. So what's that traction? So those are some of the limitations. My time is up.
Thank you so very much, man. I sincerely appreciate your keeping to time. So if I'm hearing you right, there's a big place for social and behavioral change as regards culture and mindset in Nigeria. And like you rightly said, we are doing it in our own, so many different local ways. So it's not an inability to do it. It's making people understand the import of these things. Thank you very much, Ma. So next, I would come to you, Dr. Ukire. And my first question to you is that the Ministry of Health plays a key role in shaping policies that impact women's health. Given your role as Director for Family Health, can you please speak to how the government is ensuring that health insurance policies are designed to specifically address the unique healthcare needs of women and promote gender equity?
Let me first and foremost start by appreciating NSSF and PIC for shining their light on this very important topic, promoting the awareness of women, as we all know that SDG 3 says so. In addition, we also know that the SDG 6.3 speaks to universal health coverage, leaving no one behind. And that means women health care is very, very vital. More to that is to note that women constitute over half of the population of this country. are nation builders. And they have a lot to contribute to national development. So ensuring that every woman out there has a fair and just opportunity to have the right treatment and have a good health outcome and wellness is very, very vital for any nation. I'm just giving us some preamble to what government does with respect to policy making. And just to buttress the fact that government is very much aware of the importance of health insurance for women. And also to say that in government, we have many structures. And government is patterned in such a way that different ministries, departments, agencies have specific mandates to deliver. Howbeit, it's usually in collaboration with relevant other authorities. So for governments, and particularly the current leadership of the ministry, has prioritized health insurance for women in the Nigerian Health Sector Renewal Investment Initiative. I'm sure that is why this study, this panel discussion is focused on this. And I want to thank NSS for conducting that study, because it gives us a clear picture of the situation. Howbeit, even though we may need a much bigger study, that brings more reality on the state of health insurance for women. And so the NHIA, as we all know, the National Health Insurance Authority, has the clear mandate to roll out policies on health insurance for the whole country and coordinate and ensure implementation. But I must also say that they do in collaboration with other relevant departments, such as Family Health Department, that speaks to policies on reproductive health, maternal health, newborn health, child health, adolescent and elderly health. And this is the way government will all join our hands together to work to ensure that there's adequate cover, adequate health insurance cover for all our women, particularly, I must mention the women in the rural areas, the illiterate, the uneducated women, because there's that disparity between those two climes, the rich and those in the urban. And so we must ensure equity, some level of gender equity, to ensure that every woman, no matter where you are, whether you live in the rural area, where your socioeconomic status, your financial status, you have a right to health. You have a right to life. And government has already prioritized this and is working on it. It's a journey. We are not yet there, but we are going to get there. Thank you.
Thank you so very much, Ma. A round of applause, please. I really want to appreciate our first two speakers for staying on time and hitting the nail right on the head. And I think Dr. Okire has so splendidly handed over the baton to you with that answer. So let me come to you, Prof. As a senior special advisor to the DG NHIA, what are those existing policies that Dr. Okire had already hinted at of the NHIA aimed at improving access to health insurance for women, especially considering their health-seeking behavior and the unique challenges that they face in interacting with the Nigerian health system? And I would like us to really focus not just very broadly, but particularly on these underserved women within the informal sector. Over to you, sir.
Okay, thank you very much. And you've also told me that the women kept to time. And so everybody is wondering what I'll do. And I think they've actually laid a very good foundation, a great foundation. So I'll try to focus. I mean, what we're discussing is connected to, the issue of universal health coverage, and it's something that is progressive. There is nowhere that all the problems get solved, but you want to be expanding coverage and also not leaving the very vulnerable behind. And you've mentioned those in the informal sector. Now, some specific things, because the health insurance plans that are in place have quite a number of things for women: delivery services, antenatal, and even some very specific things. Can do the secondary care that somebody will need. You need cesarean section and all that. That is included. Now, the decision about inclusion of services, like they could raise even a number of things. That decision is actually something that always gets driven by actuarial reviews, because you don't just wake up and add something. Whatever you add, you need to be sure that the premiums that you have cover it, because you still need to adjust by utilization. Every premium that you see has an adjustment based on utilization. It's pooling that happens, and it's risk that is computed before you say, okay, this is what the insurance premiums are and what people pay. So it's not like it's going to be that everything can just be added. Now, specifically, people get left behind. The informal sector really needs, there's a lot of work that has to be done. NHIA drives both that integration, regulation, and promotion of health insurance. But it's important to remember that this is within the context of, like, you have over 70 HMOs playing some role and 37 other institutions, the state health insurance authorities. Now, but to be very specific, some of the things, apart from having services for women with the plans that we see, there's a gift ship program, the group and individual program that individuals, groups, families can easily take on and enroll. But NHI doesn't just focus on that one because that's what it has available, but also checks for those things in the insurance plans that are being provided by the state health insurance schemes and HMOs. So that's some of the things that we've been looking at is what people say that they cover in states, in, with HMOs. Does it actually include the benefits that are correct? I can tell you that there are some states and some other places where you have something like somebody has health insurance cover when he's at work. But if he gets sick when he's at home, he's not covered. There are people that you have, all sorts of things when you get into the details. Now, that's some of the work that is going on. And, thanks to the Act and all of that, to check what everybody is saying that they have. As long as you have said that you want to serve Nigerians, then we'll have to check. And if it doesn't make sense, you have to do something differently or look for another business and do, so that we know that those people are not covered. Now, I said that for the general things. Now, more specifically, recently, you may be aware, NHI since September last year has been engaged in paying for women who need, CS. Those conditions, emergencies, pay. The focus is pay, and then let's sort out the bill later. So that the kind of situations we've had even in a state recently shouldn't happen. A lot of these challenges are connected to women who can't pay, who don't have that resource. So that is going on. Over 3,000 women and more than 1,000 plus, going 2,000, that has happened in Kano over the last 6 months. Verify that this woman needs this service and treat. After treating, after doing cesarean section, is it obstructed labor, whatever it is, after they submit their claims and NHIA reimburses, So that is going on and is expanding. In fact, in basically every state, there are MOUs signed. Yesterday, we were in Lagos and reached an agreement with Lagos, and that's going on. It's expanding. The other one I'll mention, and I can always give details later, is that there's a lot of work going on with the fistula, women who have fistula. One thing that you will see with every woman that has vesicovaginal fistula is that she's likely to be poor, she's missing, she doesn't have an identity, she's out there and lost. So that has happened since July last year. And these women are getting care, treated, fistula repaired, and then enrolled in health insurance so that they get cover and then given opportunity for family planning. Now that's what's going on in the fistula centers in the country. So let me stop there. And NHIA is paying and dealing with that. Yes, I'll continue.
So thank you very much, sir. No, you can continue. I have to commend the NHIA for the good work that is being done and for responding to the pressing needs that, especially with all the happenings in the recent past. Good to hear about the gift ship program, while we also pray for a time when, to have the money to pay or to be able to raise that 3,000, whatever it is to get your CS is one thing, but there will be people who come in who cannot even raise that money. So we commend you for the work that is being done, while we hope for a time when they can come in head on perineum or whatever and still get attended to and covered. Thank you very much, sir. So we'll move on to the next round of questions. And Dr. Deku, I'll be coming back to you. So maternal and reproductive health services are critical to achieving gender equity in healthcare and reducing gender-related morbidity. My question is, how may health insurance models be better designed to ensure that women have continuous and affordable access to these essential services? Over to you, Ma.
So thanks very much. I think the last presentation from Prof has actually layered that. For us to design insurance packages that meets the need, certainly we must use human-centered approaches. He has given us 2 examples. Those within the lowest quintile VVFs is an area of need in certain regions of Nigeria. Is actually across all the states. There is a mindset that you only see it in one region, but even some regions that are exemplars, as they call themselves, we still have cases of VVF, and all resulting from obstructed labor, limited access to emergencies and stuff. So in modeling our health insurances, I think we need to look at what we are signed to: the guarantee of continued care, guarantee of quality care. We've signed to it. We, I mean all of us, as benefactors and those who even offer the service. Mind you, health. Why all of us? Because health is produced in the home and is managed by the system. Okay? So many people tilt it the other way around, because it's what you start off with that give you the prerequisites of being offered survival tendencies. So which means everyone must make sure health is important on your household list. Number 1 should be health, because if you are not healthy and alive, you can't make money. You cannot educate. So that basic thing of ensuring that the insurance services cover the full hog, preconception. And Prof, I'm looking at you now. Those who are in school, out of school, young people, many nations ensure that we stretch the health insurance to cover those packages. We are doing it indirectly through guardians, right? Because a family can register I don't know, 4 children, or or and dependents. So we're doing it indirectly, but beginning to ensure that each one of us value that health insurance. Children themselves on their own, they can't enlist. They will enlist 2 families. But there are many children on their own out there, which is in the informal sector. How do we stretch that to ensure we have similar package that we're doing for VVF for out of school children, those who are migrants? There's so many groups, and like he said, we can only do it progressively. We can't do everything at once, otherwise we will be overwhelmed. That life cycle coverage, being intentional about it and face it, I think it's one of the models. Secondly, because we are mainly community-based people, we trust our communities. Are there models within our NHIA that we can use to scale community-based health insurances? We've had many pilots in this country. Can we integrate that and pari passu? Because communities trust themselves. I mean, in one of the presentation I did hear, whether it's from NSSF, where the community say they don't trust health insurance. It's not that they don't trust health insurance. They don't trust the channel. But if we make it like a community-based where they decide, I don't know, they've done it. I think Kwara had an example of a community-based insurance which focused on maternal health. And I'm sure Prof has so many of those case studies. Can we, as a special case like we're doing for emergencies, Caesars, and VVF, can we also do community-based where they can trust us as the technocrats, the providers, and those who regulate it. So the next one, I talked about gender responsiveness, because people like to see themselves in everything here. It's like, can I really see myself? Can I, like the common slang on the street, can I feel myself? Can I feel myself in this premium I'm paying? Or in this premium somebody offered to pay for me? Because there are many schemes, through charity schemes, people who pay premiums, to ensure that we enlist those in the poorest of the poorest. The third one I want to look at is, because when the last, I think the court presentation, Stephen, presented, I was curiously listening, and I'm like, now you have young people cohort, and I know NHIA has been trying to do a lot of digital and mobile platforms. We need to advance that like yesterday. So I'm looking forward to a place where I'm using my banking app. I have not visited physical bank for months. I visited once this year, last week. That's 4 months. I haven't visited bank. But I've been doing my banking on my app. Everything I need, I'm doing on my app. So to make that easy, user-friendly platform, where they can enlist. I know how many groups, Old Boys Association, Women's have advertised NHIA to, even to refer them to the office. They'll tell you, we can't find it. I'm like, if there's an app, so can we use these disruptive, young-minded creatives, these cohorts that are here to help us? Prof, I'm looking at you specifically. Why? Because my role as an enabler, policy advocacy, these policies are there, but we need to get it out. People don't want to spend time, to go. Opportunity costs. They have to spend transport money, their time living. Meanwhile, can they do it on their desk? So let's utilize digital mobile platforms, simplify enrollment, simplify claims, USDD tools like the bank do, like many communication companies are doing, and I know you have them at your beck and call. Can we just get it out, and make it easy, for people to enroll? Yeah.
Thank you very much, Ma. Excellent, excellent, excellent contributions. Please, a round of applause for her. Dr. Ukire, I'm coming to you. So many women, especially in rural and low-income communities, struggle to access maternal and reproductive health services. What strategies is the ministry implementing to ensure that health insurance schemes effectively cover these critical services for women, for all women? And are there specific plans to involve subnational level in these conversations?
Yeah, thank you very much for that question. As has already been said by Prof, a lot in the government, particularly through the Federal Ministry of Health and our agencies, are doing a lot to ensure there's health insurance coverage for women is increased. And in fact, I think for the first time recently, we had the largest enrollment, of coverage for health insurance. However, I know that one other area that I believe the NHIA is going to be focusing on going forward is to give us the data for the number of women enrolled and disaggregated by age, because we also have our adolescents. And it will also be good to know that it's very inclusive, as some of these women, persons with disabilities and all that. So, and government is doing this through the, we're all aware of the National Health Act, that through the 1% consolidated revenue fund, we now have a sustainable way of mobilizing domestic resources, in Nigeria. And this is channeled into the 3 gateways, and one of them is the NHIA. And the main purpose of this is to ensure that out-of-pocket expenses for our women is grossly reduced. We all know that compared to the men, the women have a lower economic status in this country, and majority of them for maternal health during pregnancy, delivery, postnatal, family planning services, and all that. Many of them are poor, many of them are illiterate, and cannot pay. Yet, they are huge contributors. A lot of them are farmers. They are producing the food we are eating in this country. They contribute a lot too. So we need them to be strong. We need them to be very productive members of the society. So government is doing that and ensuring that there's more emphasis. That's one thing I would say. I believe NHIA is already doing that to give more priority to the poor rural women, so as to then foster some level of equity, to increase equity. And he has already mentioned even most of the basic services, because honestly, let's tell ourselves the truth. We cannot fund everything. And so we are prioritizing based on what are those things that cause death most of the time. Also, we are prioritizing prevention. So health promotion. What are those screening services, be it for hypertension, diabetes, nutrition services, family planning? We reduce maternal mortality by 30%, screening for cancer. All those preventive services, I think, are very key and should be prioritized by NHIA. And also, working together with all the sectors of government. I told you, the government doesn't work alone. We all work together with the NPHCDA and even the emergency medical service gateway. We've been able to package a basic minimum package of services that NHIA, especially to the NHIS at national level. And I think the state health insurance schemes are also copying at various, in varied forms anyway, of these big services. Like you mentioned, it's supervised antenatal family planning services, antenatal services supervised, skilled birth attendant during labor and delivery, and all that. And I can see that my time is up. Emergency obstetric care and all that. So all those services have been prioritized and women are going to be accessing them through the health insurance. And right now, up to about 200 facilities have been empaneled for the free emergency cesarean session he's talking about, and the free VVF in about 15 facilities. So let me stop here. But government is really doing a lot, but like I said, it's work in progress. Thank you.
Thank you very much, ma'am. Please, a round of applause for her. Good to hear that there's a lot of collaboration going on between all the MDAs. Dr. Okiri had stolen my thunder a little bit, or segued us beautifully into the question I have for Prof. So, sir, is there utilization data on health insurance services in Nigeria? But more to the point, these data, are they disaggregated by gender, by disability status? And how can this data be used more practically now to source for critical funding from donors who are willing to fund health insurance programs for underserved groups, especially women?
Okay, very good question. And I'll just, something I needed to add. The NHIA is currently working on the solution that allows, let me put it as, ease of enrollment. So what you mentioned is coming, and I don't want to let the cat out of the bag. But that's the idea, beyond the 30-something offices, how can you, in 10 minutes, 5 minutes, you open your phone and you enroll? So that's called Let's All Watch Out, along with many other things. Community-based health insurance schemes, very brilliant when it comes to the concepts. The issues have always been, who is a reinsurer? If you have money, like some of the ones that were mentioned, we studied, once donors pull out, it goes. That's the end of it. So there's a lot to do in terms of separating where do citizens have information and can take action. And a lot of it is around the supply side things. Is there a midwife there? Is the midwife working correctly? Is all of that. So there's a lot of supply side things. And, beyond the insurance part. And insurance is always better when the population is larger. So the two don't have to work at that setting, But these are conversations that are ongoing and really need answers. So to add, and, from Federal Ministry of Health, like she said, there's just a lot of collaboration going on about things, and even the data aspect is one. Utilization, to be very frank, is many things. Of course, we know there's the DHIS and all of that, but we're working to see a lot of the engagements that are happening, especially through the Federal Ministry of Health, is on how some of these things can have a more unified approach. The facility that is probably next door is probably using a data system that they paid somebody to install. And so you can count the number of health facilities across the country. They are probably running different softwares. Now, to aggregate that information is a challenge, because first you need some kind of interoperability of, all those medical records things that are going on. We're not there as a country, so this is a broader challenge. Yes, you have that happening for like primary health centers, but you can see that what happens is also a lot of aggregated data. There's a summary at that point first, which might have things that are missing. How do you break it down by disability, by actual age? A lot of what comes up from there is summarized, right? And then different layers. The best would have been that you finish delivering service at the PSC, you fill it in, on a tab or something, and those details are coming centrally from there. But, we have a state level. We have state officers. We have all kinds of things. So summary data gets there, and you won't have what you want, what you're looking for. So a lot of times there's a lot of dependence for utilization data, which you're talking about, on specific facilities. Pick that or do surveys and then aggregate that and use it to do some of the things you're doing. But what I want to say is that with the digitalization agenda, which the Minister of Health, coordinating Minister of Health is driving with the team and with the parastatals, that is work in progress. And I think that the answers are a bit ahead of us, but the processes leading to that are ongoing. And I think it's for us to support it. NHIA is also putting that pressure on providers because that information is needed for actuarial analysis, which will inform decisions about what do you do with those who are disabled, what of the younger people, and all of that, and how do you now redistribute resources. So that is ongoing, and the finite answers are a bit ahead of us, but that's there's work ongoing in that direction.
Thank you very much, sir. He's been on a hot seat for a little while. Hopefully, let's turn it to the audience while his seat cools down.
There's fire here.
So at this point, we'll come to the audience. If there are any questions, any burning questions, if you have a question written down for any of the panelists, this would be the time to ask. Okay, we have one hand. Is there a mic? Okay, 2 hands and then 3. Okay. Is there a mic in the audience that we can? Over here. Over here. I think he was the first hand. Yes.
Thank you very much.
So before you start, please kindly introduce yourself, your name, and then if your question is specifically directed at any of the panelists, please do well to let them know.
All right, thank you very much. My name is Sheyi Anwo from Policy Innovation Center. I'm so excited to hear wonderful things going on with health insurance in Nigeria, particularly about maternal health in Nigeria. Okay, straight to the point. A lot of things are happening, and checking the website of NHIA and NHIS, you hardly see quality information that you can really use to take information. For instance, I was trying to look at the benefit package for malaria in Nigeria, other NHIS and NHIA, and you find out that it's just lumped up in the guidelines there. It's not broad enough. So I want to know if there are other places where we can look at when we are looking for information that we can really work with. That's number one. Number two is about maternal health of women, and I'm going to be speaking specifically to malaria, probably in the spirit of just concluded Malaria Day. And now we are experiencing funding cuts, especially to malaria services in Nigeria. And one of the areas where donors has been helping Nigeria is real preventive measure. This time around, I have to speak with IPTP for pregnant women. So what's NHIA is doing to incorporate that that we are looking at broader ways of doing things now. And even the insecticide treated nets, they are not under the health insurance scheme. They are fully donor funded. What are we doing to make sure that we are taking that one into the benefit package? Thank you very much.
Okay, thank you for that very long question and detailed question. Hopefully you got all of it, sir. Okay, over to you.
Actually, I said she's supposed to, so I will allow her to talk.
We are going to answer it together. So concerning the NHIA website, I'm sure Prof will illuminate here. And then concerning IPT, malaria, pregnancy, antenatal care, prenatal care is one of the benefit package services under the health insurance. So the IPT is well covered. I'm not sure about IPT, yes, is well covered. The mosquito treated nets are usually through the malaria program that they distribute it. Yes. I think I've answered all your questions. Yes. Thank you.
And maybe to add, let me add to that, then I say a word about the website or other sorts of information. The beauty of health insurance, and more importantly, the payment approach providers. This on itself is a journey that we should transition to, all of us as a country and health sector teams. You know, we have a historical approach which doesn't help very much, which is focusing a lot on supply interventions. So you drop this, you drop that, and a lot of times we come back, things get misused. It's nets, some people use it to make, curtains in their houses. You go some places, they turn it to fishing. Because it's not tied to individuals. And that's a problem. Now, where we should be is that as we expand and get health insurance, that understanding to flow down. If a provider receives capitation for a month for these individuals, the decision about investing in nets should be the provider's decision. Like, I'm not going to have any profit if at the end of the month, everybody that is enrolled and for whom I have received funds is just coming for treatment, injections, and severe malaria, whatever. It will make sense for me to invest in prevention so that I can have profit. So that's the kind of thing that should happen. So, but if they are receiving things and all of that, people will not think like that. But this is, so as we expand the insurance, as we expand payment of people and providers through that, it will incentivize changes in how health service is delivered. Okay? Some people will look, I'm going to do everything possible because I've received this money. I'm going to do everything possible to provide antenatal care. It should actually look, I'm going to drive ANC because this woman, I'll still have to take care of her if her expenditure is high. So let me invest in prevention and make savings. The savings is in my pocket. So that's what we should keep pushing. And as we expand, that's the idea. Those are really the solutions we should, keep pushing. And I think for the website, just lots of things, and I agree with you, not denying anything, okay? But that is in a few weeks. So if you actually look at what you have there, it wasn't what it was a few weeks ago. You will see those things on the site.
Thank you very much, sir. And thank you for those commitments that we are making to improvements, baby steps. We do have questions online, so please, I want to encourage us to be very brief, introduce yourself, limit your question to no more than 10, 20 seconds so that you can have a fully fleshed out answer. I believe, yes, please.
Good afternoon, everyone. My name is Adana Omer from Policy Innovation Center. So thank you so much for the session. I really learned a lot. So my question is to Dr. Mojisola. You mentioned one of the ways we could bring about gender responsiveness and inclusiveness is through promoting digital platforms for enrollment. Now my question is, how do we get to do it for rural places? Like, so many people in the rural areas don't really know anything about these phones that we use. They barely survive. To talk more of having all these digital devices. So how do we make them connect? How do we make them feel that this system is really what they are part of? So yes, thank you.
Yeah. So thank you very much. I think that I will pivot it back to Prof. Within the digital, because there are digital, government of Nigeria has prioritized digital public infrastructure. And like he has said, that connectivity of whether it's NIN, there's USSD, there are many options to be deployed even to rural areas that doesn't have the internet connectivity. So we have offline kind of applications. Those are technicality. So within the plan that we are waiting to be launched out soon, I'm sure her question is an intentional way of ensuring that as we are launching out, we're launching in urban and rural areas, looking at those digital platforms that can be energized offline. And there are many methods. I'm not an expert in that area, but the little I know, there are many that can be used offline. They call it offline content. So Prof should speak more to that.
Okay, yes, I think you've actually spoken to it. Yes. So in a lot of those places, even there are people that are doing POS things, right? So the solutions are there. And she's mentioned it. Wherever they get to, there'll be the opportunity for people to enroll. The bigger issue is not really about their enrolling, especially the people that we're talking about, but who pays for them. With Nigeria's poverty level, somebody has to pay for a lot of Nigerians. Even the middle class is asking for people to pay for insurance for them. So that will be the biggest issue, because once these things are open, we need to get people on board and somebody has to pay.
All right, thank you very much. I think we can take one more question from the audience and then we'll take the online questions. Can he have the mic, please?
Okay, my question wants to, I can't say it's a question, let's say a solution-based approach. Like, we're talking about digitalizing the health sector. How do we do that? I'm not talking about the whole of the Nigeria. I'm talking about the non-formal sector, especially the rural dwellers, those that don't have access to health because of finance. Probably they are not exposed. So I'm thinking, instead of talking about either it is an app design, but it should first start from the rural that has to do with physical contact with these people so that you can have engagement. Engagement comes, it will now trigger shall I say, the dormant tradition, shall I say, cultural aspect of non-reactive to the health about themselves, being caring about their health. So if you have these centers, let me say in the whole of Nigeria, it will go a long way in triggering the health sector so that people can enroll more in the health insurance. If you have a center where you have an app, even though they cannot fill it, but you have forms that they can fill. When they fill it, then you as a personnel in that place, you can first what you start is the question, what is health insurance? Then you break it down. What do you know about health insurance? Then what do you feel? You garner those kind of reactions to generate more of their needs. Thank you.
Thank you very much. Do you want to respond?
Okay, so even starting with the last thing, while it's insurance, some of the things that were, Dr. Uhiri we've spent 1 year there now, and 1 year of trying to change many things. Actual review was done before this last 1 year was 2011, 2012. There were so many things to deal with, to sort out. Actual numbers, actual days, lots of to sort out. Now, one of the nuances around this is that we can always talk about insurance. But what people want to understand, especially the people we are talking about, is not necessarily about it's not necessarily the insurance. What you're selling is access to care. So some people develop questionnaires. I'm also a researcher, and they start writing a lot of things about insurance. I mean, in their mind, that's not really, is a concept, technical concept. But access to care when you need it is what people are looking for. It's what appeals to them. So those things, we're also trying to domesticate them, make people understand what is it that you use for awareness creation, basically. Connected to it and data is what something government has been doing. When you go down to rural areas, you know that there are layers, political layers, who selects who identifies who is the poor, who is aggregating people, what names do you have? And so at the end of the day, you have 20 names, and only 3 are real people. So one of the things happen, because if you have that kind of chaos, you can set up the entire digital infrastructure. It's garbage that is entering there. They don't have identifiers. Once that's a problem, money will miss. So like this fistula and CS that is going on, part of what is happening is that everybody needs to be identifiable. So we say, these women that are getting treatment for VVF, they are getting their NIN. That's what we're doing. Because that will be the currency. The one that we have, whether they're working for formal sector, whether they're working wherever, your NIN has to be there. So it's contributing to identity inclusion, making people feel that I actually count in Nigeria. If they don't have, we pay for them, we support, we are working with NIMSI to see that no matter how poor, even if they are missing, that they get NIN. We're moving to a point where that can help if you call that there's a woman you're sorting out and all the life cost things. That this woman, you can identify her today and track her tomorrow. So that's a major focus. And then the rest of the data things are going to be sorted out once everybody can be identified. The corruption around things will also go away because money is tied to this person, and the person has an identifier, and you have to account for that. That's the kind of thing that is going on.
Thank you very much, sir. I'm at once encouraged, but almost a little bit discouraged. I'm not really sure, and I know everybody is sort of feeling that way. But we move, as we like to say in Nigeria. It's not a small problem. It's very deeply rooted in human behavior, and things take time. So I think the key takeaway is, yes, progress is being made, but it involves all of us, and we have need patience while we wait to get to where we want to be. So very quickly, the online questions. The first one I think you have already addressed. So I will skip that one. It's been asked in various forms. But the second is NHIA willing to take steps to foster partnerships with startups aimed at facilitating health insurance enrollment to ensure prompt and personalized healthcare services for enrollees?
The answer is yes. I mean, the answer is yes. And I know there are fundamental things to tidy up. There was no way of engaging people to do one thing or the other if you hadn't defined a correct tariff and fee-for-service things for providers that, fit the time we're in. There's been a lot of worsening of inflation and all of that. So that needed to be sorted out. 2 is the part that we talked about ease of enrollment. And then, of course, the third part is around complaints and how people, if some people followed the news recently, there was something about 1 hour for you to give people codes. If that doesn't happen, there are a lot of events that will but the people have to get their care. So those are fundamental things, some of the fundamental things. When citizens have a voice, it should be heard somewhere. What is that process? And then how do you respond to it? Those things, so with those things being tidied up, and I mean, there's a lot of energy inside that, it becomes easier to work with every other person. And so, yes, the answer is yes, which was my short answer. But this is a longer answer.
Thank you so very much, sir. Please, a round of applause for all our esteemed panelists. We are right now past the hour of 3. And so at this point, I will just outline some of the key takeaways from today's session. I think we all agreed that culture and our mindset has been this recurring theme, not just only with regards to how Nigerians, our attitude towards that contribution towards health insurance, being our brother's, having that mentality of being our brother's keeper and not just thinking about ourselves. But, you know, like Prof has now even brought out there are deeper dimensions, if you will, to what we're seeing on the surface. So corruption, it keeps rearing its ugly head at every stage, but we will continue pressing on and doing what we can. I don't think there's room for just giving up and throwing our hands up. We have to keep doing what we know to do while trying to tackle it at every level. But very importantly, there needs to be social and behavioral change, communication that would drive idea of health insurance becoming a social norm. That really stood out to me during this discussion. And I'm really hoping that the good work that the NHIA has been doing, especially in Kano, you talked about over 3,000 women are now covered for CS. I'm hoping that with time it can be scaled up to other states in Nigeria. Very important as well was the issue of self-care. I know at the RAMCA TWG meeting, it came up quite strongly that beyond just focusing on treatment, that there needs to be that prevention part of it. And so, you know, raising the consciousness of Nigerians, even at community level, and even within the home, you know, to that the issue starts with us. Let's show up as the most healthy versions of ourselves so that the amount of money we then need to be putting out or thinking of paying to treat is way less. And like Prof keeps reminding us, this is a work in progress. So patience is required. I think the last point I have here is really that focus on a need for collaboration. Like my director rightly said, the government can't do it all. So there is that need for synergy and collaboration between donors, government, and even community level. Like Dr. Deku had pointed out, the idea of contributions for our own good is not a new idea to us in this country. So if we can do it in other sectors, why can't we do it for health, which is priority for everybody? And so targeting this health insurance issue at all levels, really, creating that synergy in order to make it happen. So thank you all very much, sir and Maz. A round of applause once again for them. And at this point, I will turn it over to Adedayo to give us next steps.
Once again, let's put our hands together for our panelists. All right, thank you. The moderator has done a quick recap of the session, so I don't need to do that again. I would just like to call on our panelists to take a photo session with the MD of NSSF and a representative from PIC as well. So if you just oblige us kindly to take a Thank you so much, Ma. May I kindly invite the director in charge of the Department of Family Health, Dr. Binyere Mukaiwe. Thank you so much, Ma, for coming. All right, and then lastly, can I invite Prof to collect this award? Thank you so much, sir, for sharing your insights with us today. All right, thank you, Dr. Fidro. Will I just ask Ms. Esther to come and give us closing remarks and a vote of thanks on behalf of the Nigerian Solidarity and Support Fund? Thank you.
Okay, good afternoon, everybody. My name is Esther Nolu, Head of Comms for NSSF. What an insightful and inspiring conversation we've had here today. On behalf of NSSF, I would like to say a big thank you to everyone who participated in this, whether you joined us virtually or physically. We want to also say a big thank you to our panelists. It was a really engaging session. Also want to say thank you to our partners, NSIA and PIC, for working with us and making this possible. So one thing we've gotten to learn is that this is just the beginning and the conversation doesn't end here. We should continue advocating and making better policies for women. Please do enjoy the rest of it. Thank you once again.
All right, thank you. All right, so when we started, I said one of the reasons why NSSF is doing this is also push policy forward, especially to all stakeholders, right? The Ministry of Health, partners supporting government, and especially NHIA as well. We understand that women have the highest health-seeking behavior in Nigeria. We want to leverage on that to see how we can help improve coverage. You know, if we have more women, even if it's specially designed packages for women that focuses more on promotion and health prevention, right? We can help use that to scale up health coverage in Nigeria. And so once again, I want to thank everybody for coming and participating. We thank you for those that came early. We thank everyone that's spoken. We thank our online audience, and we want to appreciate you once again. So respectfully, I'll ask us to rise as we take the closing and national anthem. Thank you very much.
Nigeria, we hail thee, our own dear native land. Though tribe and tongue may differ, in brotherhood we stand. Nigerians old and proud to serve our sovereign motherland.